Dr. Ali is a graduate of the University of California School of Pharmacy. He completed his PGY1 at Kaiser Permanente, Orange County, and his PGY2 Oncology Pharmacy Practice Residency at USC Norris. He is an Aspen and HOPA grant recipient and co-author of 10 major publications. And we really appreciate his time today, so I'll hand it off to Dr. Ali for his CE presentation.
All right, thank you very much, Dr. Spahn. Okay, well, welcome everyone, whether you're on Zoom or in person. Wanted to thank you all for joining us today. Appreciate you coming in and joining us. I know the topic is quite large, so oncologic emergencies and supportive care. So I'm sure a lot of you groaned when you heard oncology. It's another oncology CE. So I know, it can be exciting. So like Dr. Taban said, I'm co-coordinating the oncology module for the students this year. And how I started off, and we have some students with us here today in that course, is I asked them how many of them are interested in oncology. Maybe had 5 people raise their hands. So we try to do this year is make oncology a little more exciting and simplify it a little bit. So I'm going to ask that question next week, which is going to be our last week of the oncology module, and we'll see where things go. But I'm curious out of everyone here. So how many of you enjoyed oncology in school? Okay, so the minority. Yeah, no, it's not an easy topic, and that's what I share with our students. Not easy, but it's evolving very quickly, and it's a growing field. So certainly one that I'm very passionate about, and many that are very passionate about. We have our PGY2 resident here as well that is so passionate about it. She decided to devote another year of her life to just focusing on it. Yeah, but I'm actually a graduate of this program as well. So I completed my residency. I started it about 3 years ago or so. I completed it in 2020 or 21. I'm losing track. 21. It's one of those. But it's quite a journey. Certainly have enjoyed the journey of it. So I know a lot of you here are not oncology experts, and I believe that's the same with our friends joining online. So what we're going to do today is going to be a little bit different than a typical oncology CE. We're going to give you the information that you need to know regardless of practice setting. And I think that's very important to focus on. You know, the folks that are dedicating their lives to oncology, did a 2nd-year residency, are board certified. Most of them already know this information. So it's going to be a little bit different here in terms of what our focuses are going to be. So it's going to include different topics. About 5 topics or so that we're going to brush up upon, and then we'll, open it up for questions at the end. So I wanted to get a sense of the audience here and to get a sense of your experiences. So how many of you have a friend or family that have been diagnosed with cancer? So for you that are on Zoom, pretty much everyone here have raised their hands. How many of you have received a question from that friend or family regarding their malignancy? Yeah, so similar amount. So it's important not only for your patients, but for your family members to get a sense of how we treat these cancers and how we support these patients that are receiving these cancer therapies. And also recognizing the signs and symptoms of an emergency, specifically when it comes to these cancer patients. And that's really what we're going to go through today. So let's just share with you a little bit about my experiences. When I took oncology in school, I did not enjoy it. So when I was a pharmacy student, did not enjoy it at all. I thought it was very meticulous, too detailed. It was kind of confusing. And I didn't have I didn't really have much rotations in it besides one outpatient oncology rotation. But I'll tell you this. The result, and I've shared this with my students, the results of me taking that course, just during my rotations probably helped save the lives of maybe 2 patients. And I'll share with you a couple stories. One story was I had a patient in the clinic. So this was part of my primary care elective, actually. And the patient was coming in, felt a lump on her breast, and was very hesitant about getting a mammogram. And I was, there with the physician, and I meet with the patient before and after her physician consult. She's very hesitant about it, was not sure of the benefits of getting it. And so she shared with her physician she wasn't really interested. The physician didn't really share benefits of getting it. And so they left the conversation with that. I met with her after that consult, and I was explaining to her the benefits of getting a mammogram and the potential, harms of not getting one. So we know for breast cancer, the earlier you catch the breast cancer, the better your outcomes are. And I was sharing with her some of that detail, of course, in lay language. And so she said, okay, I'll get one. She got the mammogram. It showed suspicious lump, signs of malignancy. She got a biopsy. It turned out to be stage 2 breast cancer. So, odds are if we didn't push this patient to get it early, this could have easily become stage 4 within a year, right? Could have metastasized for this patient. So, educating them on the risk factors, for these patients, the screening opportunities that we have are very important. And I still keep in touch with this patient, actually. The second case that comes to mind for me is my uncle, actually. So this was also after I took the oncology module, before I started residency. He was having symptoms similar to BPH, so urinary incontinence, similar to what you learned in BPH. So he went to his primary care, and right away, without running any diagnoses or labs, they put him on BPH medicine. They just assumed it was BPH, put him on finasteride. And so, I was talking to him about his symptoms, and I learned in school you have to check something called a PSA, which is a marker, not 100% specific, but it's specific for prostate cancer. And so does anyone know what a normal PSA is? Less than 4. His PSA came back at 92. So I told him, hey, you need to get a PSA, and he ended up asking his PCP for a PSA, and that's what it showed, right? So there are certain circumstances where primary care can fail. So it's our responsibility as pharmacists, as any healthcare providers, to be the advocate for your patients, to catch these things, right? And so regardless of practice setting, these things are important for your patients, okay? So that's what we're going to be talking about today is information that's really relevant to any pharmacist, regardless of practice. So here are the objectives for today. I'm not going to go through all of them, but here they are on the slide. No disclosures for this presentation. So the first topic we're going to talk about today is CINV, so chemotherapy-induced nausea and vomiting. And this topic is more of the supportive care aspect of it, right? And then we'll move into the oncologic emergencies soon after. So just to give you a little bit of background, there's certainly an unmet need for these patients. Patients that are receiving chemotherapy, oral chemotherapy, these medicines cause a lot of nausea and vomiting. So a lot of emesis is a result of these therapies, right? So you can see here, 90% of patients experience chemotherapy-induced nausea and vomiting. It's very common, and 20-30% of them experience breakthrough. So that means we're giving them medicines to help prevent their nausea and vomiting, but it's not enough, right? So I don't know about you, but I get seasick all the time. So whenever I'm on any boat, and that feeling for just like 30 minutes or so is like the worst feeling ever. And you can imagine these patients are going through this for days on end. They're just, it's nonstop for them. So that's, these things are important for patients. So oftentimes when we're treating patients, we focus on the therapeutics behind it. We're going to give you this therapy, that. And we forget to think about these supportive care opportunities for these patients. And, they're just as important, right? You can make a patient certainly miserable, and it can be very dangerous as well for patients. So here's a basic overview of prevention strategies and treatment strategies for CINV, short for chemotherapy-induced nausea and vomiting. So first, what we do is really the key here is prevention. It's much easier to prevent CINV than it is to treat it, right? So preventing it from happening is what we do. And part of the ways that we prevent it is look at the risk factors for the patient, look at the therapies that we're going to give them, and come up with a treatment regimen, a prevention regimen to prevent it from happening. And if there is breakthrough, how do we address that as well? So here's a kind of an overview of CINV. Sure, many of you didn't know there's actually 4 types of CINV. So let's say this is an example regimen. You're on day 1, you're getting your day of infusion of your chemotherapy. You can get something called anticipatory CINV even before you get the chemo. And that's actually a Pavlovian response, a conditioned response to the chemo. So imagine, you're eating a food that you really don't like, right? And it makes you nauseous. So every time you're taking that, it has a similar effect. So, patients, when they're anticipating like getting nausea from something like chemotherapy, they'll be nauseous even before they get that substance, right? So that's the idea of anticipatory nausea. And then you have acute and delayed. So acute is nausea within 24 hours, delayed is after 24 hours. And breakthrough refractory can happen, anytime after that. So these are the different types that we just discussed. And each type of CINV has influencing neurotransmitter factors. What is the cause of this CINV? So some of them, you can see like serotonin has an effect on it. Substance P has an effect on them. And anticipatory, like we talked about, it's just past conditioned experiences for these patients. So one of the ways that we can look into preventing CINV from happening is looking at the risk factors for the patient. So there's patient-specific risk factors, and there's also chemotherapy regimen-specific risk factors. So this is actually from the NCCN guideline. So you can see here the types of regimens on there. So you can make an NCCN account and you can look at your patient's regimen and it'll tell you the risk factors for that patient. And it outlines it in different risk levels: high risk, moderate risk, low, and minimal risk. So high risk means more than 90% of patients typically will have some sort of CINV. You can see the highlighted ones are some of the more common chemotherapies that we see give patients high risk CINV, right? So once you identify that, that's the first step for patients. Then you can identify patient-specific risk factors. So we identified the chemotherapy. Then you can look at the patient's past medical history. A past medical history of motion sickness, emesis before chemo, pregnancy-associated emesis, those are risk factors for CINV. Unfortunately, females are at a higher risk than males, and younger age, 55 years or less, is associated with an increased risk. There is actually one thing that decreases your risk. Does anyone know what that is? What decreases your risk of CINV?
Higher exposure to alcohol.
Exactly. So history of chronic alcohol intake.
Stop.
I mean, I wonder how you knew that. He's the least nauseous guy here. Never gets nauseous. Yes. So, I can't think of any other benefits of chronic alcohol intake, but that's certainly one of them. It's not saying that you should all go out tonight and drink a lot, but that's certainly beneficial in certain circumstances when it comes to CINV. All right, so now we understand the risk factors, right? Then we go into the pharmaceutical options, the pharmacological options for these patients. You can see these 4 basic categories here on the right-hand side. You can also see the types of medication, specifically what we're giving as well. So what you're essentially doing is, we saw, you're targeting substance P, serotonin. So you're using those drugs that target those neurotransmitters, their substances, and trying to prevent those neurotransmitters from binding to their sites, right? And so these are examples of treatment regimens that we use for these patients. So patients that are high risk for CINV, you essentially throw the whole kitchen sink at them. You target every neurotransmitter out there. You put in your 5-HT3 antagonist, you give them steroids, you give them NK1 inhibitors, and add Ativan in certain cases. Like, for example, if they have anticipatory, use it in that case. H2RA, PPI, acidity can increase your risk factors as well for these patients. And the lower the risk, you go moderate, low, and minimal, you start peeling things off, right? Obviously, polypharmacy is an issue. So the less medicines that you can give to a patient, the less side effects and the less need they have for it, right? So you start peeling them off all the way to minimal immunogenicity. You don't really have to worry too much. You can just give them something for breakthrough for those patients. So this is just an example regimen that we have out there. So we talked about the pharmacological aspects of this. This is just examples of the types of regimen and dosing that you would see in these patients. Breakthrough. Unfortunately, our prevention strategies don't always work, right? You saw the percentages of patients have breakthrough. It's very common. So you have to give them prescriptions or other options for patients that go through breakthrough and still have CINV. So you can see here the types of breakthrough options out there. I'll call out a few of them. So the cannabinoids, dopamine antagonists, you can also use some 5-HT3s in this case, some other medications on the very bottom. So these are all different options that you can use for breakthrough for these patients. And this shows you the treatment types. Some medicines are better at targeting certain types of CINV than others, right? So your NK1s, for example, they don't work well for breakthrough. They're better for delayed and acute CINV. Olanzapine pretty much hits everything. Benzodiazepines we often use for anticipatory, but it can also be used for breakthrough and refractory cases, right? Cannabinoids, you don't usually use that up front, but you can use it in certain cases for breakthrough or refractory patients. All right. So just wanted to share some brief clinical pearls on some of these drugs. So there's NK1 antagonists. They have IV and PO formulations out there. So you might see the PO formulation in community pharmacies, often dispensed for patients. 5-HT3 receptor antagonists. So your Zofran, for example. These medicines are often associated with a lot of QTC prolongation. And when I showed you the list of breakthrough meds or other options, there's a lot of drugs out there that can increase QTC. A lot of medicines that we also use in cancer treatment, including azoles to prevent fungal infections, increase your QTC. So it's often highly recommended that you're checking your QTC for your patients to prevent prolongation of it, right? So you have to be vigilant in these cases. One of the main side effects that we see with these 5-HT3s is constipation and headaches. Headaches are unfortunately very common for these patients. So, if you have a patient in the clinic telling you, hey, I'm experiencing, some nausea, but also headaches. So oftentimes we'll just say, hey, just take some Tylenol, take some ibuprofen, but it's important to assess what's causing this. And oftentimes when you have patients on these chemotherapies, one of the triggers is a Zofran for these patients that have these headaches. So coming up with alternatives is often important. We know about steroids and benzodiazepines certainly have some adverse effects with them as well. Antipsychotics, you're targeting dopamine over here. So you have those metabolic effects and EPS, same with the dopamine agonists as well in this case. Anticholinergics, so scopolamine patch. For some patients, it works very well, and others I've noticed not too much. But what's not fun for patients are the anticholinergic side effects associated with them, right? So, some patients tolerate it well and it's working for them, and some patients will not tolerate that level of side effects that they're receiving. Cannabinoids, hot topic right now in cancer. So we can use cannabinoids in the treatment or, for breakthrough patients, right? It can certainly help. But there's a lot of side effects associated with them. So one is increased appetite, which actually can be a good thing in certain patients. And the other is sedation. So if you have a patient, for example, that, not much of an appetite, which chemotherapy can cause, and is having difficulty sleeping, this could be an option for some of them. Okay. So we have our first knowledge check question. So if a patient presents with breakthrough nausea and vomiting, which of the following agents should not be considered for treatment? On the patient, on the folks on Zoom, you can put your answers in the chat. If anyone has an answer here, you can share it as well. See, exactly. So just to share with you also, the impact that you can have on your patients regardless of practice setting. So recently had a patient that was having severe nausea and vomiting. And, we didn't really understand why. We'd send her prescriptions and it's not clear why she had it, but we never really sat down with her to see the reasoning why. But so one day I sat down with her and said, let's see what's going on. She didn't understand, like, a lot of the medicines that we give her and we prescribe for her, she's supposed to take, throughout as prevention for CINV. The way she was taking it is if she had nausea, she would start taking it. So she was not taking it as prescribed. So of course I went through it with her, taught her how to properly take the medicines. And she comes back to me a week later. She said, Amir, you changed my life. I'm not having this level of nausea anymore. So you can see the impact of really counseling your patients, understanding how we're using these therapeutics to prevent CINV from happening in the first place. Next topic for supportive care is mucositis. So mucositis, you can kind of see from the screen over here. You see the guy on the right-hand side. It's a little more than that canker sore. It can become a little more severe than that. So I'll share with you the cases that we've seen before and how severe it can get. We know that chemotherapy attacks rapidly dividing cells. So that's why you get hair loss. The follicles get hit. And it can hit the epithelial cells as well. So you have sloughing of the epithelial cells in the GI tract. So mucositis not only happening in your mouth, your esophagus, throughout your GI tract, and it can get very severe. So severe, you can have entire sloughing of the epithelial cells from your mouth to your stomach, right? So, and it can be incredibly painful for these patients. We've had patients where they cannot tolerate a drop of water, how painful it can be for them. You often have to put these patients on severe pain medications, PCAs for some of them. And, they're obviously not eating as much because of how painful it is. Might have to consider TPN for some of these patients just because of the severe mucositis. So similar with CINV, one of the things that we can do is help prevent severe mucositis from happening for these patients. Part of the prevention is understanding the risk factors associated with CINV, with mucositis, excuse me. So some are treatment related, right? The types of chemotherapy that they're getting, the radiation that they're getting. Bone marrow transplants a risk factor for these patients as well. Patient-related risk factors, depending on their age, so younger age. Again, in this case, unfortunately, more common in women, females than males. Nutritional status, other comorbidities that they have, and dentition. Are they taking care of their teeth? Oral health, right? And those are below are some examples of notorious chemotherapies that have high risk of mucositis. So yes, we have our treatment options out there and prevention strategies, but there are certainly non-pharmacological prevention strategies that we can have for these patients. One is promoting good oral hygiene, recommending that they go see a dentist often is important, maintaining that. Oral cryotherapy, right? So the idea is ice chips. You're swishing around in your mouth, and oftentimes we'll give this right before chemotherapy and for certain chemotherapies. And what you're doing is you're constricting the blood vessels around your mouth. So less chemotherapy is going better, right? So that's, for some chemotherapies, that's an option. Though specifically, this is a bit detailed. For one chemotherapy named oxaliplatin, we avoid that because it can worsen some neuropathy that patients can experience. Bland oral rinses, so sometimes you recommend patients, salt, baking soda rinses for some of them, and avoiding alcohol-containing mouthwashes, using soft toothbrushes as well. There are some pharmacological treatment options out there, though I will say these are not routinely used. Some of them have, very minimal data in terms of how beneficial they are. But two of them you can see on the screen, palifermin, amifostine. These have certain benefits in some patients. The biggest thing that we can do is this treatment algorithm here is prevent the different, symptoms of mucositis. So xerostomia, the bland rinses, give them sugarless mints. For pain, you have topical analgesics. Some you can use topical lidocaine in these patients. And of course, if it gets severe, you can escalate from there. And infection risk. So a lot of these patients will be put on kind of like a magic mouthwash of sorts, where you have a combination of steroids in it and antifungals in it as well to prevent infections from happening. So here's the next knowledge check. Which of the following patient counseling points should not be given to patients on oxaliplatin therapy? Exactly. So chewing on ice chips, specifically with that chemo, would not help, make things a little bit worse for them. All right. Next, we're going to go into some of the oncologic emergencies that we have out there. So starting off with hypercalcemia of malignancy. Anyone familiar with this at all? Yeah, a little bit maybe. All right. So hypercalcemia can occur in multiple disease states, but one of them can be in patients with cancer. Some of the more commonly occurring cancers that we see this in is lung cancer, multiple myeloma, renal cell, and breast cancer. It is associated with a poor prognosis in these patients, and unfortunately, about 30% of them have some kind of hypercalcemia. Pathophysiology can occur from multiple points, but one is an increase of parathyroid hormone secretion. You can see tumor secretion of vitamin D analogs as well in these patients. And so these are, depending on how severe the hypercalcemia is, you can see different symptoms in these patients. And as the severity increases, the symptoms will start escalating quickly. So you start off with just some musculoskeletal differences, some lethargy, and all the way to, arrhythmias from the calcium. Unfortunately, there are some patients that pass away from the severe levels of calcium. We've gone a long way in our understanding of this and our treatment options for this. So luckily, this does not happen very often. But the basic treatment approach is this. Right, so you're understanding that this can occur, and being on the lookout for it certainly helps. It's also important to actually look at the corrected calcium, right? That gives you an accurate result because of the albumin bind of calcium. Next, from a pharmacist perspective, it's incredibly important to look at the medications that the patient's on. There are certainly a lot of medications out there that can increase your level of calcium. So we've had cases where we've received requests to start a patient on, for example, I'll talk about it next, zoledronic acid. And then, I'm looking at the order for it, and then I'll notice a patient's actually on supplements for osteoporosis with calcium and vitamin D that they're still taking, right? That's obviously not helping the situation at all. So it's important to look out for these. Lithium, thiazides can also increase your calcium levels. The biggest thing to really hone in on this, which is often difficult, is controlling the calcium, controlling the malignancy is the ultimate source of preventing this from happening. Right? So first, in terms of treatment options, you want some short-acting agents. So normal saline, you're essentially helping the body flush out some of the calcium if possible. You're diluting some of the effects as well. That's important. Calcitonin can be used in this setting. So you're using this either sub-Q or IM. You can see the mechanism there. There is tachyphylaxis though. So you're using this, up to 48 hours. After that, not much of a benefit for these patients. Next, you have some of your long-acting agents. So your zoledronic acids, your bisphosphonates, and your denosumabs. And what these essentially are doing are preventing bone reabsorption of that calcium, right? So these are common medicines that we use not only for hypercalcemia, you can use these for osteoporosis as well. And they have pretty similar mechanisms between the drugs. The issue with these is they don't work right away. That's why we have our short-acting options out there. They take time to work. So sometimes we'll get a request to start a patient on one of these, and within 2 days, we'll say, hey, the calcium didn't move much, let's give another one. It's important to educate these take time to work. So onset with a peak effect of 5 to 7 days for zoledronic acid. So it's important to keep that in mind. You can repeat doses, usually wait a week or so to repeat doses of these agents, right? Depending on if you're using this for osteoporosis or you're using this for hypercalcemia, dosing can differ. So it's important to know the indication and the dosing for these drugs. Denosumab is a monoclonal antibody. It's very similar in mechanism to the bisphosphonates. One of the benefits of using denosumab over the bisphosphonates is you don't have to worry about the renal function as much. But I will argue in hypercalcemia, the renal function is not as big of an issue. You can allow for accumulation and it's going to still work in terms of lowering your calcium levels. But certainly you can use either one. And this is just kind of an overview, depending on the severity of the hypercalcemia, what you can do. One is for all of them, you're treating the cancer, you're hydrating the patient. For moderate, you add on the bisphosphonates. And for severe, you can even consider dialysis in some of these patients. All right, another knowledge check. Which of the following medications should be discontinued in the setting of hypercalcemia? C. So thiazide diuretics. All right, we have 2 more. So next one is tumor lysis syndrome. So this one sounds a little intense, and it kind of is. But no, it's pretty straightforward. So it's an important topic, right? I remember when I first heard this term when I was like maybe a second-year pharmacy student, I was like, oh God, what does that mean? Yeah, it sounds probably a little more intense than it is. So a little bit in terms of background for it. Fortunately, this is a common oncologic emergency that we see in our patients. So it occurs when a large amount of tumor cells are lysed and their contents are released in the bloodstream. And we'll have a figure of this on the next slide. Very common in hematological malignancies. So you're talking about your leukemias, lymphomas, and certainly still occur in your solid cancers as well. But, you know, here's a figure of it. I think I have some sound effects. I have 3 of them. Those took me a while to make. I'm trying to find the perfect sound for them, so I hope you appreciate it. Yeah. Okay, so let's consider those cells up there, some cancer cells, right? So let's say that's a tumor over there. And you're giving some chemotherapy. So that chemotherapy is going to start killing those cancer cells. And there's a lot of cancer cells out there, right? And when you're killing these cancer cells, they're lysing and they're releasing their intracellular contents. Intracellular contents includes the potassium and includes the phosphate, calcium. Uric acid is a result of the DNA breakdown, but you're releasing these substances into the plasma and you'll start to see that level start rising in the bloodstream. So as a result of that cell lysis, you can see hypercalcemia, hyperphos, hyperuricemia. You see hypocalcemia because it's kind of binding to that phosphate, and you'll see lower levels of the calcium. When you have that precipitation of the calcium phos, it can often precipitate in the kidneys. And one of the results of TLS is that, you know, it will precipitate in the kidneys and cause AKI, right? And it's a vicious cycle that just starts worsening. Then you have AKI and you're not flushing out these electrolytes anymore. Can spiral out of control, cause arrhythmias, often, unfortunately, sudden death in these patients. But we've gone a long way. There have been drugs that have been approved in the past where you pretty much see everyone get TLS. But we have gone a long way in understanding the risk factors, again, for these patients and learning how to prevent TLS and manage it when it does occur for these patients. Actually, I wanted to shout out my podcast. It's not mine, but I was a guest on a podcast. If you want to learn more about TLS, we're going to talk a little bit more about it. If you want to learn more about TLS, there's an hour-long podcast. If you want to sleep, I would put it, you know, as a bedtime story. If you're interested, you can find it online. Just Google TLS and my name, you'll probably see it. All right. So how do we prevent this from happening? So one is catching these cases. So typical onset, once you start chemotherapy around that time, and you can see the complications we talked about. Prevention is key. Recognizing these high-risk patients, so patients that are hydrated, that already have some AKI in them or dysfunction in their kidneys, patients that have bulky tumors, high LDH. These are patients that we're really worried about. And what we do is prophylax and also treat. So low risk patients that we're not really worried about is you just recommend oral hydration, rigorous hydration for them, right? You're flushing out these electrolytes. Intermediate risk, that's when you add allopurinol. And I've certainly had patients in the past that I'll send in an allopurinol prescription. They'll go to their outpatient pharmacist and they won't pick it up because the pharmacist says it's for gout and they don't have gout. So there are other uses for allopurinol, and one of them is TLS. So, understanding that for your cancer patients, as essentially what you're doing here is preventing the buildup of uric acid. So that's how allopurinol is functioning. So similar to gout, right? But a little bit different. Your high-risk patients, again, the whole kitchen sink at them. So the other option is rasburicase that we can use for these patients, an IV drug. We'll discuss that shortly. So hydration is key. And then your medication treatments, you can see listed there. In terms of mechanism, you can see two parts. So how allopurinol works is it blocks xanthine oxidase. So it prevents the formation from that DNA to the uric acid. So you're preventing the formation of uric acid. So you're blocking that. How rasburicase works is you're converting uric acid to allantoin. Allantoin is a substance that you can readily excrete via urine. So it's much more readily excretable than uric acid. So that's how they both work. The issue with allopurinol on its own is if you already have very high levels of uric acid, the allopurinol is just preventing that from building up even more. It's not getting rid of that uric acid. So that's the benefit really of rasburicase, is to get rid of that existing uric acid that's already there. So you can see the two drugs over here. So there are advantages and disadvantages of each drug. For most patients, at least moderate risk, they'll be placed on allopurinol. You can see some of the side effect profile there. It needs to be dose adjusted for their renal function. Fortunately, it takes time to start working. It's not going to be working right away. On the other hand, you have rasburicase. So, you can see the package insert dosing there, but it's common in practice to use flat dosing. We found it's equally effective, and it's actually a cost-saving method to use flat dosing rather than weight-based dosing for rasburicase. Typically, a lot of cancer centers have protocols in place to say when you can use rasburicase or not. It's a very expensive drug. It's very expensive. Obviously, allopurinol prescription, it's going to be cheaper than using rasburicase. But I'll let you know, if you need the drug, you need the drug, because things can worsen. So let's say, if you're trying to save money and you're just maintaining the patient with hydration, allopurinol, things can worsen. If the patient's in AKI, can rapidly deteriorate, go to the ICU, be put on dialysis. So certainly warranted in some cases, and most cancer centers have it on their formulary and will rarely use it in their patients. Other TLS monitoring for these patients. So besides the electrolytes, you're looking at other aspects for them as well. Close monitoring is key for these patients. I'm not going to discuss the management of all these other, electrolytes as well, but they're in the presentation for you to look at. In certain circumstances, hemodialysis can be indicated. So let's say there are electrolytes of, for example, potassium above 6 and things are not falling, the patient's in AKI, you can certainly use hemodialysis in these patients. So the next question is, which of the following is a lab abnormality seen in TLS? A. So the rest would be hyper. You would only see hypocalcemia in these patients. Last one. Who's excited? It's finally over. Kidding. This one is a very interesting. How many of you have heard of cord compression? Okay, like 2 of you, 3. Okay. So we at Norris have a code called code spine for cord compression. And I'll let you know a little bit why we have it. So what is cord compression? Cord compression is a result of a cancer, a tumor that's compressing on the spinal cord. It's invading the fecal sac, invading the epidural space, and it's essentially pinching the spinal cord. And it can happen very quickly. It can be so severe that patients can have permanent paralysis if it's not caught in time. So I'll let you know, this is my final story, I promise. I was on rounds when I was in a PGY1. And this is before my oncology rotation, but we had patients with cancer on our service. And one of the patients started complaining of back pain, right? In my mind, it's like, okay, they have back pain. So that's just right away, I was thinking about pain management. So I was, okay, let's put them on Tylenol or what have you. And right away, the attending says, have we considered cord compression for this patient with active malignancy? I had no idea what that was. So we ended up getting imaging. You have to get imaging for this, and it turned out to be negative, thankfully. But I'll never forget that. So when you see patients with cancers, and there are certain risk factors, certain cancers that are more prevalent than others, if they tell you, hey, I'm experiencing some back pain, it's important not to just recommend some pain meds. It's important to refer them for medical care and potential scans for them, right? So what's going on here? It is fairly common, though it is only 4% of patients. 4% can certainly be a lot. Around 4% of patients develop spinal cord compression. More common in patients with breast cancer, prostate, multiple myeloma, and lung cancer. So incidence is about 19%. So it can happen. And again, what you're seeing is destruction of the bone by the tumor. You're having collapse in the bony fragments of the epidural space. You see some of the symptoms there: new onset back pain, some deficits, bowel dysfunction. These all occur, and sometimes the symptoms are slower on onset for some of these patients. So, and if patients don't have a lot of these deficits, that's a good prognostic factor. But it can happen right away for some of them. That's why we have that code spine. So if patients are complaining of back pain or have some of these symptoms, we need to act right away. We need to get scans right away. So what we do in these cases, you confirm cord compression. Often, a lot of these patients will get some decompressive surgical procedure. But from a pharmacist perspective, they're also put on steroids. It's important to start patients on steroids right away. Stat medication, you're starting dexamethasone, 10 milligrams, followed by 4 milligrams every 4 to 6 hours, and you start tapering from there. But steroids is essentially slowing the growth of the tumor, right? That's what's happening here. That's the importance of you're making sure it doesn't worsen, right? Sometimes the question becomes, do we wait for the neurological exams or results to come back before starting steroids? It's more to start steroids right away. If you're unsure, start them on steroids. Okay. So here's the last knowledge check question. Which of the following steroids should be started stat? I think we covered this very well. If there's suspicion of cord compression. So the answer is B. All right, so here are my references. My email is on the top. I wanted to thank you on behalf of USC Mann School of Pharmacy for joining us today. And then we can open up the floor to any questions that you have in person or on Zoom. If you have a question on Zoom, we'll be monitoring the chat function, so you can place it there as well. Are slides available? Lisa says yes. I wasn't sure. Thank you. Okay, well, if there's anything else, feel free to email me. Wanted to thank you for your engagement. Yes, you have a question.
Is there a reason why dexamethasone is the preferred steroid as opposed to like PED or hydrochloride?
It's a good question. So there have been studies in the past in terms of Dex being a more potent inhibitor of cellular growth. So that's why you're using dexamethasone in these cases.
If a patient's having QT prolongation, what antiemetic should they be?
So the question is, if a patient has QTC prolongation, which antiemetic should they be on? So there is not a straightforward answer besides giving them antiemetics that don't cause QTC prolongation. So there are options out there. Not all of them cause QTC prolongation. So you're going to have to play around with the regimen to make it work for them, right? Because it's certainly common. QTC prolongation can happen for these patients. All right. Okay. Well, thank you everyone for joining.